Hello, my name is Chiara and I will be presenting Healthcare System Hybridity, a conceptual framework on behalf of my team as part of the Aston Newcastle collaboration. Healthcare systems are the product of each country's social, institutional, economic, political, and cultural experiences. They have to respond and adapt to the ongoing challenges such as increasing costs due to technology and aging population and the current ongoing COVID pandemic. After the Second World War, different countries set their roots for modern healthcare system, expanding universal coverage and equal access. For instance, the UK and Italy set their NHS, Canada its national health insurance, and the US adopted different governmental health insurance schemes that covered different segmented groups of its population. Since the 60s, several reforms with equity, cost containment, and efficiency objectives were put in place to counteract challenging trends and assure healthcare system sustainability. In the first wave of reform, the implementation of universal schemes in different countries led to an increase of healthcare expenditure, requiring supply-side regulatory tools to control and ration resources. As a consequence, in what is defined as the second wave of reform, the demand of private health insurance increased as consumers were seeking easier and faster access, hampering the decreasing of total expenditure. The third wave of reform aimed to foster efficiency and quality through the introduction of incentives and competition among providers. As a result of these waves of reform, the design and role of contemporary healthcare systems are diverging from pure types as defined by the traditional tripartite classification of NHS, social health insurance, and voluntary health insurance. Therefore, we observe a convergence of whole healthcare systems toward hybridization of their financing and provision dimensions. These trends affect differently, depending on the country, the design of healthcare system. The degree of hybridization of each national healthcare system has become difficult to appraise for policymakers. While the objective of the first wave of reforms were clear, the following reforms have created complex trade-offs between competing objectives. These trade-offs are exacerbated when decision-makers have to deal with uncertainty and scarcity of resources caused by external shocks such as economic recessions and pandemics, which may threaten the sustainability of healthcare systems and their adaptability to external shocks. Policymakers have lost track of the degree of hybridization of their national healthcare system, and the literature lacks a comprehensive and unitary definition of healthcare hybridity. Few hybridity frameworks have been developed taking into consideration a single healthcare system mix or single dimensions, and this can lead to oversimplification of differences and variations among countries, overlooking transformations within a single country. To fill these gaps, we propose a hybridity framework to define at what stage of the hybridization process national healthcare systems are, to track changes and understand what direction single healthcare systems are going, and whether national healthcare systems are converging towards hybridization. To do this, we first reviewed the literature to identify the financing and provision factors that would help to build the hybridity temperature model. Therefore, we focused on prior typology and taxonomy frameworks, identifying and selecting the following dimensions that belong to financing and provision. And we categorize our dimensions of financing and provision as belonging to different mixes: public-private, mandatory-voluntary, and typology. When we refer to public-private mix, we define those variables that relate to ownerships, roles, and relationships of financing or provision actors. When talking about mandatory and voluntary mix, we refer to the nature of mandate participation to public or private health insurance schemes and providers. And with typology mix, we refer to the design components of healthcare system. Therefore, we propose a classification of healthcare system that develops through an hybridity continuum rather than through predefined categories, and that would classify healthcare systems only according to prevailing model logic. For this reason, we propose healthcare systems classification that developed through a spectrum of hybridity that has pure and hybrid models as extremes. Going forward, we complement our model, offering general propositions portray hybridity as a composite measure and process that impact the design and outcomes of national healthcare systems. With the first proposition, we argue that all contemporary national healthcare systems are undergoing a process of hybridization. And besides countries that have mixed system in place and register high level of hybridity of their financing and provision dimensions where complementary health insurance schemes coexist, such as Chile, the US or Australia, also healthcare systems that are defined as NHS and often considered closer to their pure design experience a certain degree of hybridization of some of their dimensions. For instance, the UK healthcare system, the first beverage system in the world, set important changes with the Health and Social Care Act in 2012, introducing clinical commissioning groups that foster competition among providers, aiming at improving quality and efficiency for the best value for money. And we observed the same trend within regional healthcare system in Italy, where some regions, such as Lombardy, are transitioning since 1997 towards a quasi-market system of adopting separation between healthcare purchasers and providers, competition between public and private accredited providers in the presence of a third-party payer, and patients' freedom of choice between providers. The process of hybridization of Italian regional healthcare systems is really diverse and create quite a unique example. With the second proposition, we argue that the hybridization process impacts healthcare outcomes such as quality, equity, and efficiency. The rationing of care through the introduction of benefit packages in NHS and social health insurance systems created the conditions for patients to seek voluntary private coverage that covers for co-payments or non-reimbursed services. And while the introduction of competition and complementary schemes should seek for better healthcare system outcomes in terms of efficiency and quality and to control healthcare expenditure, policymakers, on the other hand, often face equity issues that arise due to an increased trend of share of private out-of-pocket healthcare expenditure. And also countries with mixed systems such as Australia with its Medicare and private system have been affected by structural problems for the past few decades due to duplication between public and private insurance and provision of care with extensive out-of-pocket that arise equity and efficiency concerns. These examples show that the hybridization of healthcare system design, financing, and provision impact the performance outcomes, creating complex trade-off between equity and efficiency objective that often is exacerbated by the increasing costs that affect the system. With the third proposition, we argue that the level of hybridization has been impacted by the COVID pandemic. Indeed, different changes of financing and provision mixes have been put in place both in the NHS and mixed systems. For example, in Australia, the application and related consequences have been mitigated to the extent that private health insurance has been diminished to a marginal and subordinate and supplementary role. We can say that the same happened in the Italian NHS, where private provision of the so-called accredited private providers has been taken over by the public system. Our model allows for the analysis of several policy objectives and their implications on equity, efficiency, and quality outcomes. Then it provides multiple levels of evaluation of the hybridization process across different levels of healthcare systems, such as national, regional, and community, as well as the impact of external shocks and the consequences for the sustainability and adaptability. Indeed, the hybridity measure has the potential to make a judgment on, for example, pre-COVID and analyze the impact of COVID on each system dimensions. Furthermore, our conceptual model helps to identify whether healthcare systems are hybrids, describing how hybrid they are, and positioning them along the spectrum of hybridity, tracking variation in the hybridity gradient and single components over time and before and after a shock. Our conceptual model should inform future research on methodologies of a composite measure that include financing and provision dimension, with several steps and a broad range of choices on aggregation method, definition of weights to, for example, preference elicitation techniques, cross-checks and validation developments. However, possible challenges faced through this process could be data availability issues across countries and over time. Future methodologies should take into account social cultural aspects and implications. In conclusion, the ongoing pandemic outbreak has been stressing the necessity to understand where countries are at with their hybridization process, to predict and anticipate exogenous shocks, promoting adaptability and handling of critical points, to inform evidence-based responsive and timing actions with clear objective and measurable outcomes, and to inform long-term policy reforms across multiple competing policy objectives. Lastly, the value added of our conceptual model implies the identification of thresholds to inform the implementation of policy interventions on measurable performance outcomes, and the potential to inform policymakers on the implementation of targeted interventions for specific variables of interest.